Good morning, everyone. Presenting Spotted on behalf of Medicine 5. Presenting Mrs. T, a 39-year-old female homemaker from Andhra Pradesh, who were presented with chief complaints of breathlessness for 1 week and cough for 1 week. So this breathlessness was insidious in onset. It was progressive in nature. Progress from MMRC grade 1 to grade 4, not associated with any orthopnea or PND. And the cough was non-productive in nature. Apart from that, she didn't have any fever, chest pain, or palpitation. Past history wise, she's diagnosed to have carcinoma breast in November 2021. It was an extensive ductal carcinoma in situ. She also had a left axillary node metastasis, and she's ERPR negative, whereas HER2 positive. And she had received 4 cycles of neoadjuvant chemotherapy with paclitaxel and trastuzumab, and she underwent left modified radical mastectomy in August 2022, following which she also received chemoradiation, though we don't know the exact details of the same. So when the patient came, she was conscious and oriented. She was apparently in distress. She was tachycardic and tachypneic, and saturation was 76% in room air. Systemic examination revealed bilateral crepitations over the infrascapular and intraaxillary areas, moreover right side. Other system examinations were unremarkable. So a 39-year-old female, a known case of carcinoma breast, who had underwent modified radical mastectomy and had also received chemoradiation, has now presented with cough and breathlessness for 1 week. So the differentials we considered were atypical pneumonia, or a metastatic deposit with acute respiratory distress syndrome, or a possible trastuzumab-induced heart failure, pulmonary embolism, or a lymphangitic carcinomatosis. So upon working up for these differentials, the complete blood count revealed microcytic hypochromic anemia with increased RDW, and total counts were elevated with neutrophil predominance, and there's mild hyperkalemia and borderline mild hyponatremia as well. Urea creatinine was found to be normal. ABG on admission showed a PF ratio of 120, and so this was the X-ray done at the time of admission. Blood. And I think you could make out some kind of nodules over here. So in order to further characterize the lesion, we entered with the CT thorax, which showed numerous discrete and confluent nodules in both the lungs. It is more over the lower lobes with the thickened interlobar septa. So this drove us to the diagnosis of lymphangitic carcinomatosis. So basically, how will we approach multiple lung nodules? So this about that. So the most common cause of multiple pulmonary nodule is a metastatic disease. So such metastatic disease give rise to nodules that are randomly distributed with predominantly over the lung basis at the lower zone. So this is the flow chart for evaluating the nodules. So in a multinodular disease, either it could be a perilymphatic or a lymphohematogenous nodule, or a centrilobular nodule. So in our case, it was not a centrilobular nodule. It was a perilymphatic bar lymphohematogenous nodule. And among that, it was randomly distributed. It was not patchy or clustered. So, so here, if we look at the possibility of a lymphohematogenous disease, either a metastatic disease or miliary infection was considered. And since she is a known case of carcinoma breast, the metastatic disease was the top differential. So before moving into the lymphangitic carcinomatosis, we must know the primary sites of metastasis of breast cancer. So this picture shows a 15-year site-specific metastasis incidence rates by the breast cancer subtype. So here, if you look at the metastasis can occur to brain, liver, lung, bone, etc. So when we specifically focus on lung, like our patient who is HER2 positive, whereas ERPR negative, so the incidence of lung cancer is highest. It was 24.1% in this HER2 enriched group compared to all other groups. Similarly, if you look at the frequency of site-specific metastasis among patients, the HER2 positive, ERPR negative group, again, the percentage, again, it is higher in the HER2 enriched group. So a note about lymphangitic carcinomatosis. It's morphologically defined as presence of tumor within the pulmonary lymphatics. However, the tumor cells within pulmonary veins are not typically seen. So the tumor cells invade the interstitium, resulting in thickened bronchovascular bundle and interstitial septae. So it prevents gaseous exchange. Therefore, it's often considered as a visceral crisis. So it most often does not occlude the pulmonary capillaries. So pulmonary hypertension is very rare, and it is a radiological and clinical entity accounting for about 8% of all cases of lung metastasis. So this is one of the case reports of a lymphangitic carcinomatosis from metastatic breast cancer of a 37-year-old woman who again presented with cough and dyspnea. Chest X-ray revealed a non-specific infiltration. CT again showed diffuse nodules distributed throughout the lymphatic system. So this was the CT. So she was treated with eribulin. So this eribulin is a product which the mechanism is it inhibits microtubule polymerization, and it was approved for the treatment of patients with locally advanced or metastatic breast cancer. And it is also effective and well tolerated in taxane refractory patients. So the mainstay of therapy for lymphangitic carcinomatosis is definite therapy directed against treating the primary tumor, and supportive care is needed in forms of ventilatory support and inotropic support, etc. So the learning point from this case is any patient who is presenting with cough or dyspnea and imaging revealing multiple lung nodules, those who have an underlying malignancy, we should consider lymphangitic carcinomatosis as one of the differentials.
Does he have any sputum production?
No, it is non-productive.
Did you try sputum cytology?
No.
It's one of the things you can try, especially in patients. If you're going to a mission hospital and you don't have CT, that's helpful. You can do it even in her induced sputum cytology.
Thank you, Dr. Sam. Do we know this patient's HER2 new and ERPR status from outside?
Yes, ma'am, from outside.
Yes, the HER2 positive.
Yes,
HER2 positive.
HER2 positive.
I think in your studies also the HER2 positive and ERPR negative had a higher risk of lung mets according to your studies. Okay. This patient, so what are the discussions regarding the prognosis of this patient?
What did you do for her?
She was initially requiring positive pressure ventilatory support. Currently, she's on, after giving steroids, she has improved, and currently she's on nasal prongs. She's doing better.
Thank you, Dr. Sam. Any other questions from the audience? If not, we'll close. I would like to thank and appreciate Dr. Sam, Dr. Lino, Krupa, Alfie, and Dr. Shavina for your presentations.